Products are shown for demonstration purposes only. The AHA does not endorse or recommend any specific manufacturer or product. In order to show skills clearly, the healthcare providers in this video do not always use personal protective equipment, such as gloves. The cardiac arrest algorithm is the most important algorithm to know for adult resuscitation. This algorithm outlines the steps for pulseless patients who don't initially respond to BLS interventions, including a first shock from an AED or manual defibrillator. Because many patients with sudden cardiac arrest demonstrate VF at some point in their arrest, it's likely that ACLS providers will frequently follow the left side of the cardiac arrest algorithm, which we'll do here. After assessing the patient, the first and most crucial step is minimally interrupted high-quality CPR. The AHA recommends the use of audio and visual feedback devices to ensure that CPR quality is maintained and optimized during a resuscitation attempt. Treatment then branches into two pathways, one for shockable rhythms, which include VF and pulseless VT, and a pathway for non-shockable rhythms, asystole or PEA. For shockable rhythms, the first step is to deliver a shock as soon as a defibrillator becomes available. The appropriate energy dose is determined by the type of defibrillator, biphasic or monophasic, and the manufacturer's recommendations. After the shock, immediately resume CPR, beginning with chest compressions. If there are available rescuers, IV or IO access should be established. After 2 minutes, conduct a rhythm check. For persistent VF or pulseless VT, give another shock and resume CPR immediately. When IV or IO access is available, give 1 milligram of epinephrine during CPR after the second shock has been delivered. Repeat epinephrine administration every 3 to 5 minutes, or every 4 minutes as a mid-range, which corresponds to every other rhythm check. During resuscitation, epinephrine acts as a vasoconstrictor, which increases cerebral and coronary blood flow. Epinephrine does this by increasing mean arterial pressure and aortic diastolic pressure, which improves perfusion pressure to the brain and heart. After 2 minutes of CPR, conduct a rhythm check, being careful to minimize interruptions in chest compressions. If a rhythm check reveals a shockable rhythm, deliver another shock. Resume CPR, beginning with chest compressions, for 2 minutes immediately after the shock. At this point, you may consider giving amiodarone or lidocaine, antiarrhythmic agents that have been clinically demonstrated to improve the rate of ROSC and hospital admission in adults with refractory VF or pulseless VT. Amiodarone is a complex drug that affects sodium, potassium, and calcium channels. It has alpha adrenergic and beta adrenergic blocking properties, and it also blocks the action of hormones that speed up the heart rate. The overall effect is to slow the heart. Additionally, it lowers the defibrillation threshold, making defibrillation more effective at lower energy settings. Lidocaine depresses the automaticity of Purkinje fibers, raising the stimulation threshold in the ventricular muscle fibers, which makes the ventricles less likely to fibrillate. After administering amiodarone or lidocaine, check for a shockable rhythm at the 2-minute mark. If one is present, return to step 5 and work through the sequence again until ROSC is achieved, at which point you'll move on to the post-cardiac arrest care algorithm. If you are unable to achieve ROSC in a reasonable amount of time, consider the appropriateness of continuing resuscitation efforts. If you encounter non-shockable rhythms at step 4 or 6 and there are no signs of ROSC, go to step 10 or 11 on the asystole PEA pathway. The asystole PEA pathway is the option when the patient has a non-shockable rhythm after initial CPR. Give 1 milligram of epinephrine without interrupting CPR, repeated every 3 to 5 minutes, or every 4 minutes as a mid-range, which corresponds to every other rhythm check. If the rhythm after step 10 is shockable, go to step 5 or 7. If the rhythm is non-shockable, continue CPR for 2 more minutes and attempt to treat reversible causes if these have been determined. If there are no signs of ROSC, repeat steps 10 and 11. If ROSC is established, move on to post-cardiac arrest care algorithm. The cardiac arrest circular algorithm is another way of displaying the cardiac arrest algorithm. It summarizes the recommended sequence of actions after a cardiac arrest. It makes the point that not only is high-quality CPR performed continuously, but also CPR quality is monitored consistently.
Products are shown for demonstration purposes only. The AHA does not endorse or recommend any specific manufacturer or product. In order to show skills clearly, the healthcare providers in this video do not always use personal protective equipment, such as gloves. The adult immediate post-cardiac arrest care algorithm begins with ROSC. The first action is to ensure an adequate airway and support breathing immediately after ROSC. Use the lowest inspired oxygen concentration that will maintain arterial oxyhemoglobin saturation between 92 and 98%. An unconscious or unresponsive patient will require an advanced airway for mechanical support of breathing if one is not already in place. Use continuous waveform capnography to confirm and monitor correct placement of the ET tube. Avoid ventilating the patient too quickly or with too much volume. Provide one ventilation every 6 seconds. Next, treat hypotension when systolic blood pressure is less than 90. When an IV is established, hypotension may be treated with an IV fluid bolus or various drug options. A hypotensive patient should be given a fluid bolus of normal saline or lactated ringers. Crystalloids, vasopressors such as epinephrine or norepinephrine, or an inotrope may be used. At this stage, consider treating any reversible causes that might have precipitated the cardiac arrest but persist after ROSC. Obtain a 12-lead ECG as soon as possible to identify early those patients with STEMI or ECG evidence of the need for percutaneous coronary intervention. For patients with ECG evidence of STEMI or a high suspicion of AMI, attempt coronary reperfusion. ECG monitoring should continue after ROSC, during transport, and throughout ICU care until deemed clinically unnecessary. If the patient does not have a STEMI and is hemodynamically unstable, consider coronary perfusion or mechanical circulatory support. Next, examine the patient's ability to follow verbal commands. If the patient fails to follow commands, the healthcare team should consider implementing targeted temperature management protocols and obtain a CT scan, EEG monitoring, and other critical care management protocols. After coronary reperfusion interventions, or in cases where the post-cardiac arrest patient has no ECG evidence or suspicion of MI, the healthcare team should attempt to determine etiology, obtain CT imaging considering pulmonary embolism, obtain laboratory analysis, and consider a drug screen. In addition, conduct an echocardiogram and transfer the patient to an intensive care unit. For additional information on each of the steps in the algorithms presented here, please consult the ACLS Provider Manual.
Products are shown for demonstration purposes only. The AHA does not endorse or recommend any specific manufacturer or product. In order to show skills clearly, the healthcare providers in this video do not always use personal protective equipment, such as gloves. The bradycardia algorithm outlines the steps for assessment and management of a patient presenting with symptomatic bradycardia with a pulse. Implementation of this algorithm begins with the identification of bradycardia, which is a heart rate less than 50 beats per minute. Once bradycardia has been identified, first steps include the components of the BLS assessment and primary assessment, such as supporting circulation and airway management, giving oxygen, monitoring the rhythm and vital signs, establishing IV access, and obtaining a 12-lead ECG if available. In addition, consider hypoxic and toxicologic causes. The primary decision point in the algorithm is determining whether the bradycardia is causing the patient's signs and symptoms or some other illness is causing the bradycardia. These symptoms include hypotension, acutely altered mental status, signs of shock, ischemic chest discomfort, and acute heart failure. If the patient has adequate perfusion, observe and monitor. If the patient has poor perfusion, administer atropine. Classified as an anticholinergic drug, atropine is effective for the treatment of certain types of bradycardia. For example, if the vagus nerve stimulates the heart, the patient's heart rate will slow. Atropine blocks the action of the vagus nerve, causing the heart rate to increase. If atropine is ineffective, prepare for transcutaneous pacing and consider dopamine or epinephrine infusion. Transcutaneous pacing, or TCP, uses electrodes on the patient's chest to deliver an electrical impulse that overrides the normal pacemaker functions of the heart. In effect, TCP provides an external pacemaker signal. Dopamine stimulates the beta-1 adrenoceptors, resulting in improved myocardial contractility, increased sinoatrial node rate, and enhanced impulse conduction in the heart. If the patient doesn't respond to atropine, TCP, dopamine, or epinephrine, seek expert consultation. Prepare for transvenous pacing and search for and treat contributing causes, such as myocardial ischemia, drugs or toxins, hypoxia, or electrolyte imbalances. To determine the more challenging types of bradycardia, use the following tips for distinguishing the two types of second-degree AV blocks and third-degree AV block. For second-degree type 1 AV block, the PR interval will get progressively longer until a beat is dropped. For second-degree type 2 AV blocks, the PR interval will stay the same length, but random QRS complexes will be dropped. For third-degree AV block, the P wave and QRS complex will not have any relationship with each other. The P waves and QRS complexes are independently firing. In all three blocks, there are more P waves than QRS complexes. Bear in mind that the treatment sequence in the algorithm is determined by the severity of the patient's condition. You may need to implement multiple interventions simultaneously. If the patient goes into cardiac arrest, go to the cardiac arrest algorithm. Products are shown for demonstration purposes only. The AHA does not endorse or recommend any specific manufacturer or product. In order to show skills clearly, the healthcare providers in this video do not always use personal protective equipment, such as gloves. The tachycardia algorithm simplifies initial management of tachycardia. The presence or absence of pulses is considered key to management of a patient with any tachycardia. If pulses are present, determine whether the patient is stable or unstable, and then provide treatment based on the patient's condition and rhythm. If a pulseless tachycardia is present, manage the patient according to the cardiac arrest algorithm. Implementation of this algorithm begins by verifying the presence of a pulse with the tachycardia. Most symptomatic tachyarrhythmias will present with a heart rate of 150 or more beats per minute. If a tachycardia and a pulse are present, maintain a patent airway and assist breathing as necessary. Provide oxygen if hypoxemic, and monitor cardiac rhythm, blood pressure, and oxygen saturation. Obtain IV access and a 12-lead ECG if available. The tachycardia is unstable if the patient demonstrates rate-related cardiovascular compromise with signs and symptoms such as hypotension, acutely altered mental status, signs of shock, ischemic chest discomfort, and acute heart failure. Immediate synchronized cardioversion is indicated. If time permits, establish IV access before cardioversion and administer sedation if the patient is conscious. However, don't delay cardioversion if the patient is extremely unstable. Synchronized cardioversion uses a sensor to deliver a shock synchronized with a peak of the QRS complex, the highest point of the R wave. Synchronization avoids the delivery of a shock during cardiac repolarization, a period of vulnerability in which a shock can precipitate VF. Refer to your specific device's recommended energy level to maximize first shock success. Check to make sure the synchronized marker is located on the R wave before clearing and cardioverting the patient. If cardioversion is unsuccessful, consider the following. Underlying causes, the need to increase energy level for next cardioversion, the addition of antiarrhythmic drugs, and expert consultation. On the other hand, if the patient is stable, the treatment path is determined by whether QRS is wide or narrow and whether the rhythm is regular or irregular. If a monomorphic wide complex rhythm is present and the patient is stable, expert consultation is advised because treatment has the potential for harm. The therapy for narrow QRS with regular rhythm is to attempt vagal maneuvers and, if unsuccessful, administer adenosine. Adenosine slows electrical conduction through the AV node and terminates approximately 90% of reentry tachyarrhythmias within 2 minutes. Although it doesn't terminate atrial flutter or atrial fibrillation, it will slow AV conduction, allowing for identification of flutter or fibrillation waves, thereby allowing confirmation of the underlying tachyarrhythmia. If the rhythm converts with adenosine, it's most likely reentry SVT. Observe for recurrence. Treat recurrence with adenosine or longer-acting AV nodal blocking agents, such as the non-dihydropyridine calcium channel blockers or beta blockers. Typically, you should obtain expert consultation if the tachycardia recurs. Adenosine should not be given for unstable or for irregular or polymorphic wide complex tachycardias because it may cause degeneration of the arrhythmia to VF. Products are shown for demonstration purposes only. The AHA does not endorse or recommend any specific manufacturer or product. In order to show skills clearly, the healthcare providers in this video do not always use personal protective equipment, such as gloves. Intraosseous or IO access can serve as a rapid, safe, and reliable route for the administration of drugs and fluids when peripheral venous access cannot be rapidly achieved. The IO route provides access to a non-collapsible venous plexus, which is especially useful during resuscitation. Although providers should attempt to establish IV access as the first attempt for drug administration during cardiac arrest, IO access is an acceptable alternative when IV access is unsuccessful. IO access also provides an alternative route for the administration of crystalloids and colloids. Many sites are appropriate for IO infusion. See your device-specific instructions for a list of approved sites. For adults and older children, the most common sites include the proximal tibia, the humeral head, the medial malleolus, and the sternum. After the IO needle is properly inserted into the bone and appropriately secured, drugs and fluids flow through the bone marrow cavity into the circulation, though depending on location, they may first pass through peripheral circulation. As is routine practice when providing most IV drugs, all IO medications are followed with a flush of 5 to 10 milliliters of normal saline. Keep in mind that even after successful insertion of the catheter into the bone marrow, there is often resistance to infusion, which a provider may mistakenly interpret as incorrect placement. Bolus administration or the use of an infusion pump should help with this. Healthcare providers should keep in mind that certain contraindications exist. Contraindications to IO access include fractures and crush injuries near the access site, conditions with fragile bones, such as osteogenesis imperfecta, and previous attempts to establish access in the same bone. If infection is present in the overlying tissues, IO cannulation should be avoided. After IO cannulation, providers should check the site frequently for signs of swelling and needle displacement. Remember that fluids or drugs delivered via a displaced needle can cause severe complications, such as tissue necrosis or compartment syndrome. IO needles are intended for short-term use, generally less than 24 hours. Replacement with long-term vascular access is usually accomplished in an intensive care setting. If you have recently experienced the death of a loved one, you may find this video difficult to watch. Please use your discretion in choosing to view the video. In this video, we will discuss how to appropriately care for and communicate with the family of a deceased patient, as well as how to care for yourself and coworkers when you experience the death of a patient. Critical care staff can confront death frequently. In our clinical specialties, we see death that is traumatic, sudden, and unexpected in all ages, from youth to the elderly. Unfortunately, emergency and critical care settings are in stark contrast to the needs of the dying and bereaved. They are fast-paced, focused on life-saving, lack privacy, can be very loud, and tend to have a poor physical layout. The dying and bereaved need time, privacy, and to be a priority. As healthcare providers in these areas, you may have to deliver news of the patient's death to the family. Let's watch a scenario of delivering this news poorly. Afterwards, discuss how this situation could have been handled better.
Dr. Schoenfeld, 305. Dr. Schoenfeld, 305.
Hey, sis.
Hey.
What's going on with that? Any news or?
Okay, I went to see him on my way home, and we were having coffee, and we were talking, and then he just gets this strange look on his face, like he was confused, and just fell down in the kitchen.
I was worried something like this was going to happen to him. You know, he's so stubborn about taking his blood pressure meds and...
I rode with him in the ambulance, but I haven't seen him since they took him into the ER about 30 minutes ago.
Has anybody given you an update or?
No, I keep going to that desk over there, and all they tell me is that I have to wait for the doctor if I want any more information.
Are you Mr. Haven's daughter?
Yes, I'm Sarah, and this is my brother, Jimmy.
Dr. Kurtz.
Can somebody please tell us what's going on with our dad? She's been asking for a half an hour.
I'm sorry, we've been very busy, as you can see, but I'm afraid I have some bad news. Your father didn't make it.
Didn't make it? I thought we got here in time for you to help him.
He had what we call a cardiac arrest, and his heart stopped.
That's not possible. He's 68 years old. This doesn't make any sense.
I'm sorry. We tried everything we could to get his heart started again, but we just couldn't. Sometimes these things happen.
But he was fine earlier today.
I understand how you feel. I'm going to get a social worker in here, one of ours, to explain some of the details. I have to get back to some of the patients that are waiting on me in the back. Stay strong.
Wait a second. I want to see my dad. Unbelievable.
Some family members may become violent upon hearing the news. It's important to keep the family members and your staff safe in such a situation, so don't go alone. Provide information in small amounts. They will only be able to handle bits and pieces at a time. Be sure to use appropriate language to convey your support. Even though we may have the best intentions at heart, our message can come across as insensitive. For example, instead of saying, "I understand how you feel," say, "I wish it had turned out differently." Rather than saying, "It was their time," say, "This must be very hard. What can I do for you?" If you are the person designated to assist the family, use common language and not medical terminology when explaining efforts to the family. If ever you are responsible for delivering bad news to a family, remember to be clear and accurate and do it in private. You are about to play a role in one of the worst memories of a person's life. Deliver your message the right way, and you have the ability to prevent additional anger and pain from being added to an already tragic situation. It can be helpful to have more than one person deliver the news, for example, a doctor and a nurse. Ideally, family members should have the option of seeing the body. Again, this is an option, and they shouldn't feel pressured or obligated to do so. Many facilities are utilizing things such as a comfort cart to help personalize the sterile environment of the patient rooms. You should speak with your healthcare system and discuss ways that are appropriate to better help families in this traumatic time. Now let's watch 2 scenarios of better ways to explain the death of a loved one.
Beth, I got here as fast as I could. What's going on?
How's Ricky?
He's in there. I couldn't watch anymore. But the social worker's been keeping me updated.
Well, what happened? What are they doing to him?
I don't know. He was outside playing, and then he came in. He said he couldn't breathe. So I called for help, and he seemed fine in the ambulance. And then when they were bringing him in, he was not responding, and he couldn't breathe again. And I don't know what's going on.
Dr. Evans, these are Ricky's parents, Mr. and Mrs. Smith.
Hi, I'm Mary Evans. I'm the doctor who's been caring for Ricky.
And I'm Martha. I've been keeping your wife updated.
How is he, doctor?
I'd like to give you all an update in private, so maybe we could find a room.
Sure. Let's go down here where we can talk.
So I understand you didn't want to be in the room when Ricky was in trouble. And I know that Martha has been giving you frequent updates. But I have some bad news. After you left, Ricky stopped breathing. And shortly after that, his heart stopped. We worked very hard on him, and we did everything we could, but we weren't able to restart his heart. I'm sorry to have to tell you this, but Ricky died a few minutes ago.
Wait, I don't understand.
Did he wake up at all? Did he ask for me?
He never did wake up. But I know he wasn't in any pain, and he didn't suffer.
Can we see him?
Of course. I'll go talk to the nurses and make those arrangements. In the meantime, Martha is going to be here for you, and she'll be able to help answer any questions that you have. I'll talk to you again after you've had a chance to see Ricky. I am so sorry.
I know you must really be shocked and hurting right now. And I'm here to listen and to answer any questions that you might have. Is there anybody I can call for you? Is there anything I can do for you while we wait?
I don't know.
I can't really think right now.
Yeah. Do you want some privacy, or would you like me to stay?
Can you please stay?
Of course, of course. I'll stay with you as long as you'd like me to.
Thank
Yeah.
More and more, it's becoming common practice for the family to be at the bedside to witness a resuscitation. Studies have shown that allowing families to be present can actually help the grieving process. Please stress that family presence during resuscitation is an option. They should not feel pressured or obligated to stay. They should also be able to come and go during the resuscitation as they choose. Have a designated staff member with medical knowledge remain with the family at all times while witnessing efforts. It can be extremely helpful in the grieving process if they have their questions answered about what they have seen.
This is an excellent team. They've been working hard for about an hour, so she should be out soon to talk with you.
I'm Dr. Mary Evans. I've been caring for Ricky. I know that Martha has been keeping you updated, but unfortunately, I don't have any good news. You can see that we're still doing CPR, but in spite of everything we've done, we haven't been able to restart Ricky's heart. We are going to stop CPR, but I wanted to let you know first.
Wait, what? No.
No, don't stop. You can't stop.
I'm sorry. I know this is very difficult.
I understand.
Hold compressions. Stop CPR.
Oh, God.
I'm so sorry.
Can I see him?
Of course, I'll take you in.
While our focus is always on our patients, and in this case, the family of the deceased, what about us? What about the healthcare professional? We all experience both personal and professional trauma. Every person has a different threshold and range of events that can be conceptualized as traumatic. The negative outcomes from this trauma can be long-lasting. Effects can be physical, psychological, emotional, social, and spiritual. Possible examples are depression and anxiety, avoidance of resuscitation situations, hypervigilance in resuscitation situations, drug and alcohol abuse, the routinization of death, lack of compassion, and changes in worldview. We truly are the wounded healers. So, how can we take care of ourselves? In the work setting, the two main avenues are informal and formal debriefs. An informal debrief will take place within a few hours of the actual event. There is usually more involvement in this debrief because it's fresh and everyone involved is present. A formal debrief is usually 48 to 72 hours post-event. It is most helpful to involve all providers who took part in the patient's care, including pre-hospital, ED, and ICU staff. We must develop a strong, positive support system at home and work. Intentionally take time away to decompress and find a way to engage in physical activity. Exercise is extremely helpful in relieving stress and providing an outlet. Finally, be aware of your stress responses and don't be afraid to reach out for help when you need to.